Good evening, everybody, and thanks, Gaurav, for the kind introduction. It's really nice to be with the youngsters who are just waiting for their pediatric posting and looking after these cute kids and examining them and possibly preparing for their exams. So I would share my screen now. So today's topic is, can you see the...
Yes, sir. Your screen is visible, sir.
Yeah, fine. So today's topic, I would like to discuss about the emergency in pediatric and identification of and stabilizing of a sick child. When you finish your this thing and you go to your clinic, so you will need to sort of work on this part of it also. And also you can have examiner can ask you questions regarding the sick children, what you have seen and what you have done at looking after these kids. So I'll also deal with some of the important emergency cases which we commonly see in our office practice or in a hospital. So most important thing when a child coming to you is how sick is the child should be your assessment. Here we have three different categories. One is that which is not life-threatening. Child is fine, she'll come to the clinic, he'll be going around, he'll have mild cough and he'll be having some mild fever, etc. These are not life-threatening. You can just give them some medicine and there are the same. There's another extreme case that is life-threatening. Child is having respiratory failure, child is in shock, child is having convulsions. These are really life-threatening. You need to act immediately and resuscitate this baby. In between these, we have potentially life-threatening. That means you have to identify this potentially life-threatening kids. And if you don't act there, these children will go to a life-threatening scenario. So you should be careful when you see this and manage these kids there. So basically, any sick child, whether it is pediatrics or it is adults, whatever the cause, whatever the organ system involved, the clues to the recognition of a serious and deteriorating physiology, just you need to know about the three things. That is, if they have anything to do with the CNS, what is the symptom or the signs? They will have abnormal behavior. When they have a problem with respiratory failure, what's the clinical signs or symptoms? What you see is a abnormal respiration. The same thing with the cardiac thing. Abnormal circulation is the clinical signs and symptoms. So when a child comes with you, a sick child, you need to just look at these three things. That is abnormal behavior, abnormal respiration and abnormal circulation. So every sick or potentially sick child, you just need to ask or do 6 things. That is, you should ask about the behavior of the child. How is this child? I'll come to this later. Whether the child is feeding well. How is the output, urine output? These are the 3 questions you need to ask. Look at the appearance, how the child is looking, how is his breathing, how is his circulation. You need to look at it. Listen to the speech or the cry of a child. That's very important. Many diseases can be recognized by cry of a child itself. Breathing and what the mother says. It's very important because many times mother will tell you, doctor, I feel my child is sick. So you may find it nothing wrong with the examination, but always listen to the mother. She's the one who's always with the child and she'll be able to do this thing. Then you feel for the pulses, the warmth of the extremities and some of the diseases like say for example kerosene poisoning. You can smell, with the smell of it itself, you can recognize. Now there is always a 4th sign other than your heart rate, respiratory rate and temperature. BP and oxygen saturation. All of us know during this pandemic how much of pulse oximeter were used. For everything we would sort of check the pulse oximeter, see our saturation as normal or not. So what is the equipment for all these things? What you require? You just need your special senses. You look, you hear, you feel and you do the saturation monitor or BP monitor or take the temperature. These are the three things. You don't require anything more than that. You just need to give some time. Look, listen, and feel for the patients. Okay. So question is, what are the three main things you would ask to rapidly assess a sick child? See, I still remember a long time back, these patients who are coming from a tribal area, they don't know how to approach them. I saw one patient coming and some mother sitting with the baby there. So I just saw her when I went into my OPD clinic. I saw some patient. Again, when I came back, I saw this mother. Then I asked our nursing staff, please, what is happening there? This baby, actually, she had come from some faraway tribal. She don't know how to go about or how to navigate the OPD. So what happened was that this baby was dead there. So she was just sitting there and seeing the thing. If somebody had seen that call, it would have been saved. So the three main things you need to ask rapidly to assess the child is, you need to ask for the behavior. Usually what the child does when he comes to the clinic, he is very active. He is so interested in your toys around. He likes to talk with the mother, and wherever see this patient, he is not interested. Mother is trying to tell him something and he is sort of a disoriented sort of a thing. So behavior is very important. Then second is feeding. Usually though mother tells every time the baby is not feeding well, but actually if the baby is taking less than half what basically the baby is usually taking, that means the baby is not well. So it's very important for us to ask about the feeding in a small child. Third is the urine output. Minimum times a baby should pass urine is about 5 times. Anything less than that means the baby has got dehydration. Circulation is compromised. So next is what? Look and appearance, behavior. Look at the gaze. You saw that gaze. He was not playful. He was lethargic. And sometimes what happens is a child who's in shock, he's hypoxic. That is the time when they're agitated, anxious. He'll lie down, again get up and look around as an anxious this thing. And interactivity. Usually what happens is when a normal child comes, what happens is he's so interactive with the parents, surrounding. He always likes your toys around and he likes to see around because children are very inquisitive. So what happens is a sick child, it is decreased interaction with the surrounding will be there. And consolability. What happens? A crying child, usually he's a well child. What happens is you with the rattle or any toy, you try to console, he'll be consolable. But a sick child, whatever you do, he will not be consolable. Look at the posture and tooth. See, limp child, any problem with the CNS, central nervous system, baby will be limp. He'll be having stiff like meningitis. You can have a curled up. Neck retraction will be there in meningitis. Feeding well, not feeding, I've already told. And always look at the pain. As you look at the babies and children, you will know when a child is sick or not. The pain. You will actually see the pain in this thing. As you sort of practice seeing this patient, you will be able to see whether this child is in mild or moderate this thing. See here, look at the breathing. See, this child is having head blogging. Head blogging is there. So this is actually they're about to get in respiratory failure. You should not allow any child to go to this stage. It is very important. So other respiratory look-alike signs are whether the child has got tachypnea or bradypnea, slowest bradypnea. For example, if you've got a respiratory paralysis, central nervous system depression, you get a slow breathing. Pneumonia, bronchiolitis, asthma, you get a tachypnea. Whether there is thoracoabdominal. Normally in small infant, they have an abdominothoracic type of breathing. In an adult, they have a thoracoabdominal type of breathing. Sometimes what happens, you have Guillain-Barré, you have polio, you have any central nervous system. So what happens is their breathing becomes difficult. And because of the paralysis, it can be abdominothoracic type of this thing, which is dependent on your diaphragm. Then regular or rhythm of the thing. You know, different types of breathing is there depending upon the area of involvement of CNS. Apneustic, atastic type of breathing, etc. will be there, which depends upon which area of the brain is involved. Look at the retraction, because why does the retraction come? There is obstruction. So whether it's a mild obstruction or moderate or severe obstruction, You should see. Look at the circulation. See, this is a child. We can see the picture which has got in shock. So you can see that child is in shock. Mottling is there. Mottling of the skin is there. If the child is hypoxic, cyanosis will be there. And they can have diffuse sweating, what is called as a diaphoresis. Child is in shock. They can have that diaphoresis will be there. Look at the other causes like bleeding. For example, if there's a road traffic accident, whether he has fallen down, whether there's any bleeding disorder in a child, something like that. Fractures also. What has happened is now high-rise building. Child is so inquisitive, he goes up and falls down, and he comes with the multiple fractures and head injury, deformities. Sometimes we should be very careful that lot of child abuse is happening nowadays, especially post-COVID. We have seen because of the loss of livelihood, lot of child abuse. Whatever problems are there, they take it up on their kids. Rashes, different type of viral exanthematous rashes, meningococcal rash. They have severe bleeding. That is, that petechial rash will be there. Dengue type of rash. Then measles. All these rashes you will be able to diagnose in the OPD. And listen for the cry, like high-pitched cry, usually where you get in CNS, you get respiratory sounds. For example, you can have rhonchi, you can have crepitation, you can have stridor, etc. Speech, usually a healthy child, he'll be able to speak. A child who has got Guillain-Barré, child has got polio, they will not be all. Child who has got a central nervous system where there is a recurrent laryngeal nerve paralysis, they can have a twang, nasal twang can be there. They will be not able to speak continuously. They have to be breathless. Always, as I said, think about the mother's concern. Give importance to the mother's concern. You may not find anything, but if the mother says, "Doctor, I feel this child is not well," please give importance to that. This is a stridor. Where do you get stridor? You get it in this is a stridor, upper respiratory. You get a croup-like thing where acute laryngitis, acute laryngobronchitis, etc. You get stridor. This is the wheeze. You can hear the wheeze. Where do you get wheeze? You get it in asthma. You can hear this wheeze there. Then you have a grunt. See, grunt is always at the terminal airway, like alveoli. What happens is the child tries to keep the alveoli open at the end of expiration. So you get this grunt. Pneumonia, alveolar involvement. Pneumonia, you get grunt like this. So recognition of ciliary important. That is, you need to check the respiratory sounds. But always beware of silent chest, especially child is not able to breathe. Complete respiratory depression, severe asthma, hardly any air going in and out. It is a ominous sign. You need to act immediately. So now feel for the pulses, especially you are trying to look at the circulation, peripheral and central pulses, because what happens in shock? Child has got a sepsis, septicemia and shock. The peripheral vasoconstriction occurs. So you don't feel the peripheral pulses well. But central pulses will be felt. That indicates that there is some amount of shock which is there. A child is in shock, will be cold. Sweaty palms, heel soles usually indicate poor perfusion. If the child is warm, it is okay. But sometimes there is what called as a warm shock. They'll be warm in the initial phases. And there is what is called as a capillary filling time. I'll come to that later. Always look at the injuries. He may have fallen down. Sports injuries. He might have fallen down from the flat or hematomas. This you need to sort of undress the child and look for all this, even because what child abuse, what we see is father trying to push the child's head onto the wall, cigarette burns, all those things we have seen. You should, because as it is increasing, your generation need to look at it, because my generation hardly any cases were there, but there is increasing incidence of child abuse which is occurring. So that's why you should keep that in mind. So where do you assess the capillary refill? This is a simple one test where all of you should know that it will indicate that whether the child is in shock along with other things. Like you cannot only rely on capillary refill time, but you need, along with the heart rate, along with the respiratory rate, along with the blood pressure, you can make an accurate assessment. Where do you do where do you check for the capillary refill time? You check at the skin of the sternum or the digit. You can see the picture, what is that. Apply the blanching pressure for 5 seconds. You press it for 5 seconds, then remove. If it comes back to normal, that means within 2 seconds, then it's normal. Anything which is more than refill time to more than 2 seconds, then it is not a blood. But make sure it is at the level of the heart, not below this thing. Then coming to the step 5, the smell. So what are the condition would help? Like for example, you have DKA, diabetic ketoacidosis. What smell you get? You get an acetone smell. There are multiple conditions, what is called as inborn errors of metabolism. You have a different types of smell, like a sweaty odor. You can have a sweaty food. You can have a maple syrup, urine disease, where you have a maple syrup like smell which is coming there. Then poisoning. Of course, you know the garlic smell of the poisoning. And you can have kerosene poisoning when the child has taken that. There are different things. Because if you are earlier had smelled these things, you will be able to diagnose within minutes that this could be a thing. So always need to measure the vital signs. So only problem with the pediatric is different age has got different respiratory rate, heart rate, blood pressure and all that. So this is available in any of your books. So but only thing is you should know when it is warning signs, because any child who has got as per this chart more than this or less than that, you should be concerned about it. You always measure the temperature. Again, sometimes peripheral and central temperature, core temperature we take, because more than 3 degrees centigrade, that means the child is in shock. Pulse oximeter, you all know the importance of pulse oximeter, your generation, even because of the COVID. We know any child who's got a pulse oximeter reading of less than 92% in a room air needs urgent attention and to be looked at what is the problem with that. Especially smaller children, they can go, because what happens is their glucose reserve is little. So they can go for hypoglycemia. So hypoglycemia has got a terrible effect, especially in small newborns and infants. The lifelong cerebral palsies they can have. So that's why you should be very careful that make sure the children are never going for hypoglycemia. Some of the things you need to remember throughout your journey as a doctor is these values. That is pulse. Any baby or a child who has got a respirator, the heart rate which you can, when you palpate or hear, is more than 120. So you should think of ventricular sinus ventricular tachycardia. So capillary refill time of more than 2 seconds is not normal. If BP in kids is more than 1 year, there is a formula that is 70 plus 2 into age. So that is it will give your lower limit of a systolic blood pressure. Heart rate more than 60 in a newborn, more than 50 till age of 1 year, more than 40 per minute till 5 years is not normal. As I said, pulse oximeter more than 92 in a room air is not normal. And glucose, because in your clinic also, wherever this thing is there, you need to check the blood glucose in every sick child. So if it is less than 45 in day 1 of life is abnormal in any child. Hypoglycemia in children is less than 50 of the whole blood glucose is termed as hypoglycemia. So now a child is coming to you, you have done a rapid assessment. It requires just 6 steps. What are the 6 steps? That is, you have asked, you have looked, you have listened, you have felt, you have smelled and you have measured. This is all that is required. Just you need about 3 to 5 minutes to do that. So what happens is that we hardly give time for our patients. So there was a study from Hyderabad which said that an average pediatrician spends about 3 to 4 minutes. All are so busy practitioners seeing 100, 200 cases. So you hardly have time. So you have to make a practice of picking up a sick child and not to miss the findings in the child. Now from assessment, we need to go to triage. Triage concept is still not there in India, except for bigger hospitals, corporate hospitals, some medical college. So what is the meaning of triage? Because triage is you are giving access to a sick child, priority to a sick child on an early basis and seeing them when they come to your clinic. So there are three, because many countries have got a different levels of triage. One is resuscitation level 1, that means it's urgent. You have seen a very sick child, you need to resuscitate, you do it urgently. Triage 2 is amber or yellow color, just like your traffic lights. Remember this, traffic light. And green is triage, green is non-urgent. So when you call it a triage 1, you look at these 6 things and ask about the behavior, look at the behavior, respiration and circulation. Ask these 6 things. Ask, look, listen, feel, smell and measure. So this you ask. If a child is unresponsive or altered conscious or lethargy, heart rate is either more or less than what is normally taken up, inadequate breathing, he is not able to breathe, he is having some problem, moderate to severe respiratory distress, marked stridor, he has got shock, that is, as I said, capillary refill time is more than 4 seconds, BP is lower than normal for the age, he has got cyanosis. This is an emergency. You need to act fast, stabilize. He may need oxygen, he may need fluids, he may need intubation. So this is what you need to do that. Level 2, again you go through the same thing, behavior, respiration, circulation, ask this. So look at these 6 things, points. Then here, level 2, amber or yellow, infant is unconsolable, not feeding, atypical behavior is there, heart rate and respiratory rate outside normal range for age, mild to moderate stridor, mild distress, capillary refill time more than 2 seconds but less than 4 seconds. These are the children we need to observe closely. If you don't treat, if you don't observe, don't send them off. The child may deteriorate fast. Level 3, this is green. After going through all this, no, these children don't have no history of recent behavior or appearance change. I told you 3 things, that is their behavior, the respiration and circulation. These are the only 3 things you have to look every time. Heart rate and respiratory normal for age or mildly deranged. CFT is less than 2 seconds. BP in normal range for the age. This is not urgent. You just need to treat the symptoms or the disease and you can send them home. But mind you, there is always exception for any rule. Sometimes these exception doesn't hold good. What are these exceptions? When would you triage a child more serious than actually he is? That means that though it does not fall into a category of red, but you still feel that this child need to be observed. What are these situations? Any sick child less than 3 months, for example, I will give you a child less than 3 months with a fever, the chance of having a severe bacterial infection, systemic infection is very high, almost about 14%. So any child with less than 3 months with fever, you need to observe or do the blood test to prove that it's not having sepsis. Temperature is more than 40 degrees or he is having hypothermia. Suspected ingestion of an unknown substance, you don't know what he has eaten, he is not able to, people are not able to tell. Or unknown quantity of a known substance, how much he has eaten, you are not able to. These are the children we do. Any child with a severe pain, especially we get in pediatrics what we call intersuption, that is the intestine go inside one to another and the gangrene can happen. They come with a severe pain, torsion of the testis, then you can have a torsion of the ovaries, severe pain they can have. Any illness in a child with severe malnutrition. When we were there, we used to see so many malnutrition children and we have taken the rounds in the night, morning, they are no more. They used to die with 4H, if you remember, hypoglycemia, hypocalcemia, heart failure, and hypothermia. These are the 4H which used to kill the severe malnutrition. Burns, the major, if it's got more than 10% of the body surface area or it involving airway, because swelling can have, they can have stridor and they can die. Purpuric crashes or target lesion, meningococcemia, think of that. Discordant physical finding, that means the child is looking sick but you are not able to find any physical finding. or child has got a finding, but child is active playful. This is a discordant, but these are the children you need to be careful and observe for the thing. And always, as I said, mother is the one who's always with the patient, her child. She knows the best about her child. If she says, doctor, something is wrong with my child, please give your ear to her and make sure that you really exclude some severe this thing. Here you can see, let me go through 3 case scenarios. That is, this is an infant presenting with a fever for 2 days, cough for 2 days, sleep is disturbed, feeding well, and passed urine twice in 4 hours. Behavior is all right, interactive, breathing fast, 54. So child is 11 months. More than 50 is not normal. Heart rate is 118. Peripheral pulses well fed. Capacity is normal. BP within normal limit. Temperature is 39.2. Saturation is 94 in room air. You can hear Ronca in this child. So this is how to categorize. You can see this. See this baby is breathing. Look at the intercostal retraction of this baby. So this child has got a mild derangement of the nature of his breathing. These parameters are within normal. Most of the other parameters are not. So this is non-urgent. You just need to admit and give him some this. See, this is again a second child, which is 2-year-old child presenting with fever, cough for 4 days, not feeding well, less active, decreased urine output. He is lethargic. Look at his face. He's not interested. He's just seeing nowhere. Breathing is fast, 62. 2-year rate is very high. More than 40 is abnormal. With moderate to severe retraction. Heart rate is tachycardic. Peripheral pulses are fast. CFT is prolonged. BP within normal limit. Febrile saturation is less than 94, 88%. This is the time categorized. He is sicker than the case 1. He is hypoxemic. He is in a compensated shock. It is urgent. You need to urgently take care of him, admit him, going fluid, give him oxygen and treat. This is amber. So urgent this thing. The last case scenario, 3-year-old baby brought with vomiting, watery stools for 3 days. He is inactive. No urination for last 24 hours. See how many times the baby has to pass urine? At least 5 times in 24 hours. But here there is no this thing. Vomiting and watery stool could be because of gastroenteritis. He got dehydrated. Drowsy, reacting only to painful stimuli. You can see his face, isn't it? Tachypneic, sighing respiration, highly tachycardic, 176. Peripheral pulses are feeble. CFT is really prolonged, more than 5 seconds. Not recordable BP. Hypothermic, saturation is very low. So how do we categorize? This is the child which needs blood sugar to be done. It is only 20 milligram. He is in decompensated shock. That is, whatever compensated mechanism of the body has failed, he has gone in for decompensation. The tachypnea may be because of the acidosis, hypoxia and hypothermia. He is also in, so his category will be red. See, red. This needs immediate intubation, giving him fluid, the inotropes and all those drugs need to be given. So every sick child we see, you need to ask about this. Ask, look, listen, feel, smell and measure the thing. This is all that is needed to be a good clinician. You just need to use this to become a better clinician. So that is very important. So every sick child you need to categorize. Emergency needing resuscitation. Potentially sick child can deteriorate very fast or non-urgent. So emergency resuscitation, stabilize. If your place can handle in the tertiary center, fine. Otherwise, stabilize the child. Don't send it just like that. Please stabilize and then transfer. Potentially sick child, stabilize, observe closely. Non-urgent, treat and follow up. So it is very important to triage a sick child rapidly and either initiate stabilization or resuscitation depending upon this thing. This is very important. We need to stabilize initially. Don't please send your patients just like that. On the way, they can have problem. Many of the time, there was death on the way in the ambulance itself. So basic principle, regardless of the etiology, information required for the assessment and management is same for all children. It's same. So all you need to just look at those 6 things I told you. Simple clinical tool. What do you require? You just need your special senses to recognize whether it's sick or potentially sick child. So very important, because kids don't give you time. Unlike adults you have time. So kids will deteriorate quickly. So you need to act in time. So I will just go through some pediatric emergencies in the office practice, which will help you in future. That is, these are the things. One is cut and lacerated wound management, epistaxis management, umbilical granuloma, rectal prolapse, incarcerated hernia, subungual hematoma, foreign body removal, ring removal, penile zipper injury, which you see, and miscellaneous procedures will be. So it's very interesting. If you see, how do you bring, many a times what happens is, child at birth, during their christening time, they would have put some small ring on the fingers. As the child grows, what happens, it becomes sort of a bigger than the ring itself. So they will come to you with this difficulty in taking out that ring. There is a simple procedure which we use the string. What you need to do is, see, if you see that A is there, no, you just need to put it under that ring and have the string come across the ring. Then you can slowly, proximal end of the string, you can pull forward and distal thing to take it out. You see here, this is the one which has come below the ring. You just have to pull it slowly. As you pull it slowly, the ring will come this thing. This is a very, very easy procedure. So many of the time we see this penile zipper injuries. What happens is, child, without knowing, looking at somewhere, just pulls his zip and his prepusal skin gets stuck in the zipper. So this is two ways we can do it. If it is what you can do is, you can put some mineral oil onto the zip as well as on the penile area. So usually it will soak and the zipper will come out easily. But if it does not come out easily, then you can use a scissor, strong scissors, to cut the bar of the zipper fastener. If you say this is the zipper fastener, so here you need to cut so that open it. Or second thing, these are the dentition of the zipper. So here what you can do is, you can cut the whole zipper and cut here between the dentition so that it will open up and you can get this thing. So this is, many a times we have children will bang their finger on the door, or while praying they can have, you can see this hematoma. It is really painful. If you keep this hematoma here, just allow it to be there. It's at least for 2-3 days. It's highly painful, and this back thing will be there. When they come with that, what we do is, we can just heat a needle and just put it on that. It will make a hole and remove the hematoma, and that pressure inside would have relieved and the pain would be relieved for the thing. So second, one more thing is, we get paraphimosis reduction. If you see this, the penile, this thing, what happens is, when it is pulled back, the prepusal skin is pulled back, it won't go back. Now what happens when it doesn't go back, then there is compromisation of the circulation. So what happens, there will be edema formation, then further it will not go back. So how do you do that? If you have a paraphimosis reduction, kindly squeeze with your palm and the fingers and compress the glands to reduce the edema. What happens when you squeeze? Blood will start going back. So that will reduce the edema of the penile, this thing. Then slowly you can manually reduce, like how I can show from all 4 direction. You can just pull back the prepusal skin into the thing. So once you do that, it will look like paraphimosis reduction can be there. Or you can do little more, which is not coming down. You can do a dorsal nerve block, so which will reduce the swelling as such, and use a Babcock clamps and try to pull it back. This is difficult. This is usually done by the surgeon. We would not do it. Many a time we get rectal prolapse in children. What happens is, they can have pinworm. Whipworm. Whipworm infestation is very common. Or a child who has got a recurrent diarrhea, who's malnourished. What happens is, their ligaments gets lax. So weak, the muscle gets weak, that anal floor area, rectal floor area muscle. So they can have rectal prolapse. It can be partial, it can be complete, or sometimes you get it will go one inside the other, giving rise to interruption. So the best way to try to sort of reduce it, you need to make the patient in a knee chest position. Just hold it there, use your gloves, and just you need to push it inside with your fingers. And usually what happens is that it will go back inside. So sometimes what happens, you can, if you don't have that, just use the paper napkin. Just put your with the small fingers all the thing and insert that thing and leave the paper there. Automatically it will comes out and the rectal prolapse is reduced. So there's one more thing what you get is umbilical granuloma and in newborn this thing. Earlier we used to use the cauterization with the copper sulfate. Now we use the salt, the crystal salt, the hard rock salt. If you do, salt is hygroscopic. What happens is that it will absorb the water and reduce the thing. If it is not possible, not able to get down, then you can use either silver nitrate to cauterize that, or you can use a just tie a ligate with a silk thread so that it will go off. Then sometimes, many a times, this is very common. What we get is children playing in those things suddenly hit their teeth to a some stone or while playing to the wall, and there will be whole avulsion of this teeth which occurs. If within 15 minutes, if we can put it, it will take up because all those ligaments are there which will get regenerated and it will hold on to the thing. If within 15 minutes, if they can put it back. So here you can see, just wash it with the saline, then with your hand just put it inside. See here you can just put it inside the tooth avulsion, put it inside, hold for some time. Hold for some time, about 15 minutes or 20 minutes, it will take up. But only thing is maximum 1 hour, but 15 minutes, before 15 minutes, many a times almost about 90% chance that after the avulsion, the tooth remains there. So management of pulled elbow, it's very common in 1 to 3 years, subluxation of the radial head. And what happens is, usually what happens is this kid will be walking behind the mother or father, and father will be holding the hand and she'll be there and will be pulling. Or sometimes you pull with both the hands up. So what happens is there is subluxation of the radial head. It's very painful. They'll be crying because I remember my wife was bringing my child when I was abroad. Almost about 5 hours of flight. She had it in Mumbai. This subluxation. She was crying all that 5 or 5.5 hours flight toward there, where I had to take her immediately to the orthopedician and do it. But if that time, if they had known that how to do it, it is very easy. You just need to pull the elbow, holding your arm and forearm. If you can pronate with the partial flexion, it will come back again. So this is one of the easiest thing to do. I think as a first aid, all the doctors should know how to reduce the pulled elbow. There's no need for x-ray, there's no need to show it to the orthopedician. So you just have to do it. See, if a child with like this, he is in a typical pose, he won't be able to lift his hand. So in extension he has, just you need to pull the elbow in a pronate, then you need to supinate and do a elbow flexion, like how it is shown in this picture. His elbow radial subluxation will get reduced. And one more thing what we commonly see in kids are management of epistaxis. That is, they can have bleeding. So this is because of the Casbach's plexus. It's very superficial, and especially in places where there is a dry climate, especially in winter, they have a lot of bleeding. So this we need to sort of, best thing is to tell them is to hold the baby on your lap, just make him forward and just compress the dose tightly for about 5 minutes. You can put a cold compress also. Or you can put a bogey, which is a job of the ENT. In a small peripheral hospitals, you yourself might have to do. You can just this thing, nose, you can put this bogies and stop the bleeding. So this is the anterior nasal packing hydrocell. That is, as soon as you put it inside, it absorbs water and because it gets swollen up and compresses the bleeding blood vessels. And this is a nasal foreign body because babies are very inquisitive. What happens is they will try to put so many things. We get this small beads, then ground nuts, small thing they try to put it inside and they get this problem. So what you need to do is many a times just tickling and making them to sneeze will bring out the thing. But if it's not there, you can just put, if there is a ENT, it's fine. If there is no ENT, what you can do is you can put this thing through the nose and try to get the foreign body from the thing, because this is an oral thing which we used to see the ear. The same thing you can just put it in the nose and get rid of that. So sometimes what happens is there is a foreign body. This is what is called as a parent's kiss. What happens is that if there is a single foreign body in one of the nostrils, the mother closes the other nostril and try to suck it in. Many a times it is possible it comes out the thing. So sometimes the kids, what they do, they put foreign body into the ear. So these are the common foreign body instruments which the ENT people use. See, what you need to do is, like, if there is either there's a lot of wax or there is a foreign body, you can just put a direct stream of water, warm water, into the ears, so that water gushing out will displace the foreign body and bring it out. Make sure that you use lukewarm water, and if there is a perforation, it is contraindicated. Many a times what happens is, these kids while playing, they can put something chemical, this thing, into the eyes, and eyes will burn like anything. They are not able to open the eyes. So what you do is, you just need to first, before irrigation, so the best thing is to do the irrigation. Just put some anesthetic eye drops and you wash with the 1 liter of normal saline. You can put the normal saline there, you can see here. With that, you can just keep irrigating with the saline. And repeat if the congenital pH, but that we usually don't do it. But keep irrigating till that irritation goes. Many times we see this wounds and cuts and lacerated wounds, but nowadays we use these gums. This thing, just you need to hold the lacerated wound together, put this thing, it will get absorbed by itself. Or there is what is called as a steri-strips. You just need to put it over the wounds and it will heal by itself. So this is stapling, but some of the places they use stapling. It is very easy to do it, and bigger cuts you can use this stapling. So last one is obstructed hernia. That is, sometimes what happens is, this inguinal hernia in the small children, because their inguinal ring, the fascia about that just gives away, and you get the intestine into the scrotum. So what happens is, they come with severe pain, and what happens is, once it comes out, because of the inguinal ring is small, it doesn't go back. So what happens, sometimes it sort of gets obstructed, or the circulation to that area starts getting compromised. It can become gangrene. So what you need to do is, you first make sure that you take out all the gas and stool from the rectum. Then you hold the inguinal ring tightly, and slowly with small pressure you can put it in. Many a times it will fail, but sometimes you can get rid of the obstructed hernia in children. So these are the common surgical and medical emergencies what you see in the children. So it's very important, because there are so many emergencies which can come, but these are the common ones. But as a pediatrician, we should know that these emergencies are anytime it can come, because it does not say that on this day they are coming. So very important that we need to look, see, feel, smell, measure, all these things we need to do, use our special senses so that we can do that. Thank you very much.